Hello, everybody. I'm Amit Verma at the Albert Einstein College of Medicine, Montefiore Medical Center, and I will tell you about targeting the TGFbeta pathway and also the IRAK pathways in myelodysplastic syndromes. These are my disclosures. So, myelodysplastic syndromes are serious hematological diseases that are characterized by reduced survival and significant mortality and morbidity. These curves show the overall survival in patients with MDS, and we compare it with a known morbid cancer, lung cancer. As you can see, even at the low and intermediate 1 stages, MDS patients do have adverse clinical outcomes. At these stages, at the low and intermediate stages, the risk of transformation to AML is less than at intermediate to and higher stages. But the patients do have bad survivals and bad outcomes even at this low risk stage. And the reason is low blood counts or cytopenias, neutropenia causing infections, anemia causing repeated transfusions, iron overload, and thrombocytopenia causing increased risk of bleeding. So we need newer approaches to raise blood counts in low and intermediate 1 MDS patients. This is a slide which shows a generalized cartoon showing what's happening in the bone marrow in MDS patients. So this is a disease that is a stem cell disease. And many years before patients present to our clinic, there is a mutation or an epigenetic event or some kind of a genetic alteration that has occurred in a clone in the hematopoietic stem cells. You get abnormal hematopoietic stem cells, which gradually expand in the bone marrow and lead to cytopenias. And during the low and intermediate risk stages, there is an inflammatory component in the bone marrow with many different cytokines that are elevated. So if we can figure out pathways that are causing dysplasia and hematopoietic suppression, we can think of ways to reverse them and increasing blood counts. We started working on the transforming growth factor beta family many years ago. These are very well-studied cytokines that have very important functions and mechanisms in hematopoiesis. So the TGFbeta ligands act on a set of receptors that then phosphorylate downstream proteins called SMAD proteins. And these SMAD proteins are transcription factors. So for example, TGFbeta binds to TGFbeta receptors 1, 2, and 3, which then phosphorylate SMAD2 and 3. They join with each other, they go into the nucleus, they associate with many different other partner proteins and then cause things to happen at the stem cell level as well as differentiation of erythroid cells. Why are these important? Many years ago, we had shown that when you look at MDS bone marrows and compare them to controls that have anemia and other causes of cytopenias, but not MDS, in MDS we find a significantly elevated amount of phosphorylated activated SMAD2, and also the number of cells showing this activation are greatly increased. We also showed that the SMAD2 increase is partly related to loss of this protein called SMAD7. So SMAD7 is an endogenous inhibitor of the TGFbeta pathways, and we found that SMAD7 is very greatly reduced in MDS. We also showed that this is partly driven by a microRNA elevation called MIR21. So SMAD7 is down, and it leads to increased signaling from firing of the receptor, which leads to ineffective hematopoiesis and low blood counts. So how do we reverse this? We can reverse this by blocking these pathways with TGFbeta inhibitors. There were two novel compounds developed many years ago by Acceleron, Celgene, and now BMS, sotatercept and luspatercept. These are modified activin receptors. So sotatercept is modified activin receptor 2A, luspatercept is modified activin receptor 2B that are fused to the Fc domain of human IgG. And they bind, these ligand traps bind to molecules that were supposed to bind to activin receptor 2B. So others, and we have shown that luspatercept can bind to a molecule called GDF11. This GDF11 molecule is part of the TGFbeta receptor family. It also causes SMAD2 activation and phosphorylation. Here we show plots that in the presence of luspatercept, GDF11 is not able to activate SMAD2 in erythroid cells as well as leukemic cell lines. We also showed in series of experiments that if you take serum from MDS patients and expose normal stem cells to it, they are not able to form normal erythroid colonies. You see this band 3. This is a marker of terminal erythroid differentiation. MDS serum exposed colonies have little band 3 compared to the controls. But now when we use luspatercept, it binds to the inhibitory substance in the MDS serum and again rescues erythroid differentiation. We also showed that the SMAD2/3 complex binds to a very important erythroid transcription factor, GATA1, to the enhancer, and then inhibits erythroid differentiation. GDF11, we were able to show suppresses late stages of red cell formation. The early stages are not that affected, but the late stages, the GDF11, the red line shows less erythroid cells and macrocytosis in the GDF11 cells. And also we showed that GDF11 levels are actually raised when you look at MDS gene expression data. So to summarize a lot of preclinical work, in MDS, there is ineffective erythropoiesis, and in some cases, there is a block in the late stages of erythropoiesis. The elevated levels of EPO are seen, but EPO is not able to affect this late stage of erythropoiesis. We also find elevated SMAD2/3 signaling and impaired erythroid maturation. In the presence of luspatercept, binds GDF11 and some other ligands, we see an increase in late stages of erythropoiesis. So phase 3 trial, the Medalist trial, was done evaluating the efficacy of luspatercept in patients with anemia with very low and intermediate risk MDS with ring sideroblasts. This was presented at the ASH plenary, published in NEJM, and FDA approved for treatment of MDS 2020. And these were the final data. RBC transfusion independence lasting 8 weeks was seen in 37.9% of patients on luspatercept compared to 13% in the placebo arm. When we looked at hematological improvement erythroid, which is a more looser endpoint for weeks 1 to 24, 52% of patients with luspatercept achieved this versus 11.8 in the placebo. So this was a significant difference and resulted in approval for luspatercept. Now, this second part of the talk, I just wanted to introduce you to another very exciting preclinical discovery, which is now in clinical trials in MDS and is showing early signs of activity. So this deals with a signaling cascade affecting a molecule known as interleukin-1 receptor activated kinase, or IRAK. So IRAK4 is responsible for getting the signals down from toll-like receptors, IL-1 receptor, through the MYD88 protein, and it then phosphorylates IRAK1 and 2, which leads to activation of TRAF6, which leads to stimulation of this very important NF-kappa B transcription factor, which leads to more inflammation. So along with Dr. Dan Starsinowski in Cincinnati, and Dr. Jackie Bortwood and Dr. Palagatti in Oxford, we had shown that when MDS patients have U2AF1 mutations, they have more of the active forms of IRAK4. So IRAK4 exists in two forms, an active long form and an inactive short form. The long form has this death domain which joins with MYD88. So here, immunoblots show these are normal bone marrows, more short form, and these are leukemic cell lines, more of the long form. And you can see more ratio of the long to short in MDS and AML. We were also able to show that when you have MDS patients, if they have high IRAK long, they tend to have a worse survival compared to low IRAK long. And this is because when you have patients with MDS with a splicing mutation in U2AF1, they retain exon 4 and leads to more production of the IRAK long. Here you see U2AF1, healthy controls, more of exon 4 is being retained. So this IRAK long form results in activation of innate immune signaling. It leads to more phosphorylation and more activation of NF-kappa B. And then leads to more inflammation from these cells. So to summarize this part, expression of long IRAK4 correlates to reduced overall survival in AML and MDS. U2AF1 mutations result in exon 4 inclusion, resulting in more long IRAK form. And now I just want to show you some unpublished data. So this phenomenon is also seen in SF3B1 mutations, which is the commonest mutation in MDS. But here, SF3B1 mutations lead to retention of exon 6, the complete exon 6. So we show that the long form is more in SF3B1 mutants versus healthy controls. And when you look at SF3B1 mutations, there is more retention of the IRAK long form and exon 6. Finally, I want to show you some data with a drug that's an inhibitor of IRAK4. It's called CA4948. This drug is able to inhibit NF-kappa B activation. These are biochemical assays with THP1 cells. And this is a NF-kappa B reporter assay showing inhibition of NF-kappa B with this particular IRAK inhibitor. We were also able to show that this IRAK inhibitor causes increase in myeloid differentiation from MDS samples that have SF3B1 mutation. So we took MDS samples with SF3B1 mutation, grew them in the lab, then picked them up and did flow on them. And we show that there is more CD11, CD14 expression in the drug-treated ones compared to the control. And this is one sample, this is another sample, and they also made more myeloid colonies. So I talked about a block in differentiation seen in MDS. And now we can see that blocking IRAK4 leads to rescue of hematopoiesis. We also tested this drug in vivo, basically in mice that were xenografted with MDS samples containing the SF3B1 mutation. They were treated with the drug or vehicle. So we saw that when we treated with a vehicle or placebo, the MDS clone increased in size after 3 weeks. But when we treated with the drug, the clone size went down. And this shows data collected from multiple samples, multiple xenografts. The drug was effectively able to decrease the size of the MDS clone. So just to summarize, TGFbeta, IL-1RAP, S100, toll-like receptors, all these important cytokines play very important roles in causing MDS. And downstream in the cells, we have activation of IRAK1 and 4, TRAF6, interleukin-8. All of these are published papers that then stimulate MAP kinases as well as NF-kappa B and lead to more inflammation. So this is a very important pathways that suppress hematopoiesis. And by blocking them with approved drugs like luspatercept that blocks the TGF-beta part, or with IRAK inhibitors, we can increase hematopoiesis and decrease the MDS clones. There is an ongoing trial with CA4948, which is an IRAK inhibitor in patients with AML and MDS, and we will eagerly await the results of these trials. In the end, I want to acknowledge the people in my lab who have done these studies. Gaurav is leading the IRAK studies. Tushar, Shamisha, Srinivas are leading the TGFbeta and the luspatercept studies. Close collaboration with Dr. Dan Starsinowski in Cincinnati, who had looked at the role of IRAK in MDS, and Dr. Uli Steidl, who has been a close collaborator on the work on stem cells, and Drs. Jackie Bortwood and Andrea Pelagatti in Oxford, who have generously shared all of their RNA-seq and gene expression data with us. Thank you very much, and I'm happy to take any questions. Thank you.